Doctors is joined by expert consultant endocrine surgeon Mr. Radu Mihai. Today we're discussing adrenal issues and surgery. Good morning, Mr. Mihai.
Good morning to you and to everybody listening.
It's really nice to have you here. And could you tell us more about yourself and your work?
So I'm an endocrine surgeon, a specialty related to the treatment of tumors in endocrine glands. That would be the thyroid, the parathyroids, and the adrenals. So I'm a consultant surgeon in Oxford, where I've been working for the last 15 years, and endocrine surgery is my subspecialty interest. For adrenal surgery, I have a very large volume practice. Every year expecting to see at least 50 patients, sometimes 70 patients with this condition. And though this number doesn't sound much, it's in the background where this is a rare operation, and the average number of cases done by surgeons in the UK, it's been reported to be 1 case per year. So from 1 per year to 50 per year, it's a huge jump. And that is based on a tradition whereby colleagues from other centers have referred patients to Oxford, and we're trying to build and keep this pattern going. So altogether, by now, I've done in excess of 500 adrenal operations. So the topic we're exploring today, it's very close to me, and I'm very keen and very interested in this. So thank you for having me today.
Not at all. It's wonderful. Like I said, it's wonderful to have you here. So let's get started with the questions. Can you have surgery if you have adrenal insufficiency?
Yes, this is very much a medical rather than a very surgical question, but all surgeons have to be aware of this condition. Adrenal insufficiency, whereby somebody's body is unable to produce enough cortisol from the adrenal glands that have been destroyed either by tuberculosis, as it was the initial case reported by Addison maybe 150 years plus before, or by bleeding, or by tumors, or been removed. Wherever the cause why the adrenals don't work well enough, these patients cannot produce cortisol, and therefore they cannot respond to stress in the same way like you and me would do. And therefore, any surgery being a significant stress to the body, these people are at risk if the steroids that they take on a daily basis are not managed correctly. So the patient will arrive already informed, and there is a hope that a big initiative from the Society for Endocrinology would have reached by now the patients who've been encouraged to carry a card, an emergency card, to present it. They are encouraged to wear a bracelet or a necklace saying, I have Addison disease, I need steroids, if somebody finds a patient like this hit by a car in the middle of the road. Because at that point, when the stress increases rapidly, these people survive only if the steroids are increased. And so there is a huge concern. There is an awareness of the problem with the anesthetists, with the surgeons, with everybody involved in such patients, that they will need to be recognized. They will need to be prioritized on the list to start early in the morning, double the dose of the steroids they take, continue with intravenous steroids after the operation has been done, and then judge how to alter the day-to-day medication while they recover. And with all this put in place, these patients should travel through life with no real problems. The problems only occur when they encounter a situation that they lose control, because most of the time these people are in control of their life. They will be super educated, they should be aware of their needs, and they should verbalize it to those looking after them. But if, God forbid, they run into an accident, as I said, let's put a car crash, disaster, they lose the ability to inform the others. So the others will have to react to their needs. So the short answer to your question is yes, absolutely. Patients with adrenal insufficiency should be served well enough by the medical system so that they can have an uneventful experience, no different than anybody else, providing all these extra measures are put in place correctly.
Wow, that's really very interesting. I really wasn't aware of it in that much detail, and it really does sound like it's so important to raise awareness of people that have Addison's disease, for
Yes,
example.
absolutely. Because as I said, the stress response that we can mount very easily when the adrenal glands are in place
Mm.
involves a huge rise in the cortisol levels
Mhm.
that keep your blood pressure, keep your energy, keep your ability to fight with the stress, disaster, weight loss, blood loss, temperature loss, whatever what is the immediate medical emergency that puts your life at risk.
Mhm.
And that stress response with the cortisol, it's a favorable one. It's what keeps us alive. While for these people, they can't. They are just flat. Or they are even worse than in a good day when they would have taken their tablets with the steroids replacement. So if they're not able to swallow the tablet and the body needs more anyhow,
Mm.
they are in a massive, rapid risk of severe deterioration.
Right, fantastic. Thank you so much for letting me know. So, let's go into the second question. What is an adrenalectomy?
Oh, you see, that's the trouble. You have troubles to even pronounce it. This is the problem with endocrine surgery. It's a concept hidden behind many words that are not familiar for our day-to-day life because
Mhm.
we don't come across them on a regular basis. And
Mm.
so the awareness of a patient would be a surprise most of the time. The diagnosis would be a surprise, and the whole discussion about the condition would be a surprise. So
Mm.
if we have two adrenal glands, one above each kidney in the body, an operation to remove the adrenal gland will be an adrenalectomy.
Mhm.
And so this is what the topic of our conversation to follow will be, because we're going to discuss patients who end up being recommended to have one or both,
Mhm.
rarely, adrenal glands removed.
Right, okay. So why would somebody require an adrenalectomy?
Very good.
Perfect.
So an adrenal operation would be indicated in patients who either present with symptoms suggestive of excessive function of the adrenal glands, and I'll discuss that in a minute, or if they present with a tumor in the adrenal glands, most of the time being picked up on a scan done for a completely different indication. So for the first part of the examples I gave would be somebody who turns up with high blood pressure, somebody who describes very unusual symptoms that on their own could be caused by many other causes, but when they present together as a package should be suggestive of a tumor in the adrenal gland. The most dramatic presentation is to have a tumor that makes adrenaline, excess adrenaline. Adrenaline in you and me is designed to keep us to fight or flight in face of disasters. And so you would have your heart rate increased, you'll have your blood pressure increased, your eyes will dilate, your muscles will be ready to jump in the hope that will remove your body from the disaster dangerous situation. Now, if a tumor makes too much of these chemicals, of this adrenaline, so to say, you will experience these symptoms for no good reason. You're not in trouble, you're not in danger, but the body discharges all of a sudden large amounts of this adrenaline in the body, and that in itself creates the danger to you. Because in large amounts, your blood pressure can increase to very dangerous levels to give you a stroke or a heart attack. Your heart rate would go so fast that your heart might struggle to keep up, to function at that sort of rate. You would feel what is described an imminent sort of feeling of death. And once all settles, you become again a normal person. So by the time you get to be seen, people will say, well, maybe you're a bit anxious or mad or inappropriate. Why would you describe all of this when this minute you look so normal and so perfectly okay? So such patients have good few years of experiencing these symptoms that are difficult to put together until somebody recognizes them as a pattern suggestive of this condition and initiates a test that will prove that indeed at times they make too much catecholamines. So that would be one example, somebody having a tumor that makes too much hormones. If you make too much cortisol, the chemical we discussed earlier on, a hormone, not a chemical, too much cortisol will make you look in a very different way than other people, because you put on weight, but you don't put on weight like so many others who struggle to control their weight. You end up with a very round face called moon face, with a big belly and small legs, and you're described as lemon on sticks, with no muscle power, while a lot of people obese still have power. They move their body without any trouble. If your weight goes up because of steroids, your muscles are so weak that you can't come out of a squat, for example. So all these functional tumors are not very common, are pretty rare. They present with symptoms that for many clinicians are difficult to put together because they've not seen another patient like that last week or last month. Maybe some of them never seen a patient like this, because that's the incidence of dysfunctional tumors. Okay, and as a second line, the one I said, it's you go for a scan, you have a kidney stone, you have a bowel trouble, and you end up as an emergency admitted. As part of that, you'll get a CT scan. The CT scan checks the whole part of the body that analyzes, not just the bowel. So the adrenals would be visible. And so in some patients like that, all of a sudden the adrenal is described to have a small tumor in it, which is called an incidentaloma. Again, a strange word, difficult to pronounce, but it's trying to say some tumor found by chance, incidentally, no relation to your complaints. You came after, I don't know, you fall off a bike, you have a diverticulitis, you have gallstones, you have something else for which somebody thinks, oh, a CT scan might help. You go for one reason, you come up with another diagnosis. And then based on the size of that tumor and so on, and based on a long process of assessment, some of those patients will end up needing an adrenal operation. So I would say that these are the two big groups of people that will end up being recommended to see one of my colleagues or myself who do this operation.
Great, thank you. Is it major surgery? What's involved in the procedure?
Well, majority of these operations can be done through what is called minimally invasive surgery. That would be a few small cuts made on the body, one to put a camera and 2 or 3 to put the instruments to work with. And if it's done through the back, it's called retroperitoneoscopic surgery. Again, a long word describing that you work in a space in the body at the back, that it's a sort of virtual space. And the benefit of that, and the reason we like it more and more, is that it's comfortable. We're not wired up to feel that much the skin on the back as much as maybe the skin on the front of the body. And it keeps you away from the insides, meaning from the bowels. And so you're likely to recover very quickly. And we started more recently to have some patients going home same day. If the camera is put from the front of the tummy, it's an experience maybe similar to what you would have seen in friends or relatives who had the gallbladder surgery. Again, 3-4 cuts at the front, camera in place, operation done, maybe 1 night or 2 nights in hospital. So for that sort of things, you think, well, this is not a big deal. Now, when the tumor is much larger in diameter, or it's suspected to be cancerous, then you end up with what's called an open adrenalectomy, whereby a large incision is made under the rib cage to have access to the tumor. And the incision in itself interferes with your core muscles, with your 6-packs, so to say, and that limits your physical ability for the first few days or weeks afterwards. And the whole impact on the body from that sort of operation becomes a lot more serious. And so you'll be expected to be maybe 5, 6, 7, 10 days in hospital.
Right, absolutely.
And at the very extreme of the practice that we come across very rarely, but it's a segment of the work here in Oxford, that we built up over the last 10 years or so. It's our patients who come with tumors that are so big that a single surgeon of a single specialty will not be able to do. And we had cases done with cardiac surgeons for tumors that try to invade into the big vessels of the body, where for that, certainly you will spend maybe a week or two in hospital, and probably you will need good few months to recover from something of that extreme attack on your body, so to say.
Yeah.
So it's a large spectrum. For the vast majority of people, would be an easy experience, providing it's done by somebody who does enough cases. And for those who need something out of the ordinary, I think we aim to create a referral pattern whereby a few hospitals in the country to offer something like that, so that people grow in confidence to do it and patients grow in confidence to travel to such places.
Yes, sure, absolutely. And how long, well, we mentioned it a little bit, but how long does it take to recover from this surgery?
Yeah, so recovery, it's a sort of more generic word. The initial physical ability to stand up and look after yourself should be back within a day or two, as I said, for the vast majority of people. And then there are a few things that would be specific to the condition that you've been treated for. If you have the one which is called Cushing syndrome, whereby you make too much cortisol, the fact that the adrenal tumor that was removed was the source of so much cortisol makes the remaining adrenal gland inhibited and unable to work normally for probably about 3 or 6 months, even sometimes even more. And in those 6-12 months, you are relying on steroid tablets, a bit like the patient I described at the beginning of our conversation. And so you will have maybe 3 months or 6 months of regular appointments with the endocrinology team, regular changes in your medication, until you become again able to function with the remaining adrenal gland. And this will happen, but it's slow. So for those people, the recovery might take a year or 6 months. For many patients, you recover within few days. Another interesting group that is growing in interest are patients that had a cancer somewhere else in the body, and that cancer, part of the nastiness of it, has spread into the adrenal gland, and you come to have the adrenal gland now removed if that is the only place where this spread has happened. Again, those people by now come already aware of surgery, because most likely they had surgery for the original tumor, and then they come to have this, which by comparison, probably it's a bit easier than having had your lung operated on or your kidney removed, which are the two common reasons for these metastases in the adrenal gland. So there is, as always, a spectrum of recovery sort of timeline, and that will be discussed with individual patients. It's not something to scare you. It's not something to panic you. Losing one adrenal gland makes you function perfectly normal on the other adrenal gland, at least at some point in the immediate future, if not straight away.
Great, thank you so much. Final question. What's the biggest concern after an adrenalectomy? And how can people manage their quality of life after this?
I think the immediate concern are complications related to the operation itself, and that relates to bleeding. The right adrenal gland is joined through a tiny little vessel into what is called vena cava, which is a large blood vessels that we have. It's formed by the veins that drain the blood from the leg and then takes the blood from the kidneys and then travel through the liver to go back to your heart to bring all the blood from the lower part of the body. So it's a massive blood vessel. If that is injured in any way, or if the control of the vein draining into it is lost, certainly bleeding is an issue. And that's why it's procedure that should be done in bigger numbers, as much as the rarity of the disease allows it, in each unit, so that the surgeon is confident to handle the problem, the team is confident to handle any potential complications, everybody involved in the process can recognize if this happens, and there is a process in place to deal with it. So it's called rescuing. No? So sometimes complications happen, but the problem is not the happening, is the failure to rescue the patient from that position. So there is a huge drive to concentrate work in centers doing at least 6 cases per year. And again, doesn't sound like much, but will not be easy to make it happen, considering what is the current position. And I can only be super grateful to everybody who has sent patients to us to end up doing 50, 70 cases in a year, and to pull that sort of volume from a wider region, obviously not just from our own town. So if there is no immediate incident after the operation, you expect to stand up, start to eat and drink, move around, go home the following day, and the quality of life to slowly return once the physical mishappenings are settled. Inconvenience of a small cut on the tummy, a scar to heal on the skin, and so on. The quality of life should be much improved, because if you had a functional tumor and the symptoms go, you think it's fantastic. If you had those attacks that I described with too much adrenaline and they go away, you think all of a sudden you're fantastic. I met young women who are making too much testosterone from these tumors, and they thought it's a change in their behavior, because too much testosterone, some of them had more than 2-3 times more than a man will have. That much testosterone changes your brain, makes you aggressive, makes you violent, makes you angry, because it's wrong. Something drives you in a way that you should not be driven. Well, for them, it's fantastic improvement in quality of life. Others feel no difference. They say, well, I had a metastasis, for example, it was removed. I feel more reassured, but I don't feel any better or worse because I didn't know I have it anyhow without the scan. So there is a potential to feel something, but the benefit of it is not on just how you feel on day to day, is the safety for your years to come. By removing that adrenaline making tumors, you decrease the risk of heart failure, you decrease the risk of a stroke, and so on. By removing a metastasis from a cancer, you hopefully gain a few more years of disease-free, what it's called, where there is no suspicion that that cancer comes back. If you remove a tumor that maybe it's cancerous, well, you settle your panic and your concerns if it's proven not to be cancer. And if it is cancer, well, then you've been treated for a very serious condition that was needed. So in a way, it's not something that you want to avoid. If so it happens is needed, I think the priority is to look for who does it for you, where should you go? And listen to fellow patients who've been through this. There is a good patient support group for people with such adrenal tumors that those more computer savvy will find easily, and ask. Feel empowered to ask the surgeon, have you ever done it? Have you ever seen somebody like me? Because you're a rare patient when you need this. It's not something that everybody sees every week. No, you're something that, God forbid, the person in front of you might have never seen one, and that's wrong. That should not happen. You should be seen by people who've done it, who do it on a regular basis. And that is the message that slowly will sort of enter into the service provision of this country.
Great, thank you. Well,
it will enter. It will have to enter. Sorry, if I can just make this comment, because
no
this
problem.
is a sort of a positive political swing. We all are unhappy, and we're going through a time when there are strikes, there are debates on the news, the sort of political atmosphere around medicine is not favorable. But there's been a very favorable undertaking organized by the government, so to say, because it's called GIRFT, Get It Right First Time, where it's a nationwide review of service delivery in many areas of medicine, trying to understand how much variability it's in the care of many conditions. And one such exercise happened for the delivery of endocrine surgery, and it came with some recommendations that I mentioned a few times, whereby the work is likely to be focused in hands that do at least 6 a year. And if you do something more complex or more unusual or more dangerous, you should have a record to have done at least 12 a year. And this now it's an initiative that hopefully will impact on how different hospitals react to this handling of rare patients. If you've never seen one like that in one hospital, maybe you refer it to your neighboring hospital who does a lot more than that.
I think it's quite reassuring to know that as well, and that there are people like yourself that are, excuse me, that are around to be able to help people with such a rare condition, you know. And I think that's what I feel like I've got the most out of this interview, and I definitely feel educated as well.
Thank you.
Yes. So, thank you so much, Mr. Mihai. Like I said, it's been very educational. And if you would like to arrange an appointment or consultation with Mr. Mihai, visit his Top Doctors profile at topdoctors.co.uk.
Thank you for today.
No problem. Thank you.